Thank you, Eva, for inviting. Thank you, Bertrand. I did some changes this morning in this presentation because considering also that tomorrow there will be a complete session devoted to new drugs, so I will focus mostly on the results we have with current strategies and less with the new drugs. So I will start like where Armando finished. So over time, we are observing an improvement in the outcome of patients with follicular lymphoma, at least in terms of overall survival. These are the results coming from the US experience. Also, these are our experience in terms of time to treatment failure. There is an improvement, but if we consider how many patients relapse or progress under treatment, also with the best treatment we can offer, at 5 years we have more or less 50%, or if they maintain 59% of cases need a second treatment. And what we also know that subsequent treatments, at least on historical series without rituximab and the new agent, so the length of remission after every relapse is shorter compared to the previous. So in conclusion, although we have a better outcome now compared to the past, a significant proportion of patients need at least a second chance. And starting with the second chance at time of first relapse. So Michele and Gilles discussed also on the potential role of observation at time of diagnosis, but somebody also suggests to maintain also on observation patients who relapse with an asymptomatic follicular lymphoma. Once we make a diagnosis of follicular lymphoma today, so we continue to follow patients for the rest of their life because we know that they can relapse. So today, most of the relapses are diagnosed during an asymptomatic phase because we perform CT scan, because we visit patients, sometimes we perform lab tests. But there is still a relevant proportion of patients that at time of relapse do very well. And so there is also room not to start immediately with the salvage therapy. Mostly considering that some of these patients are elderly patients with several comorbidities, so probably they have no 40 years of life expectancies after a relapse. So we could also decide not to add toxicity to the patients if there is no sign of disease progression. But if we exclude this proportion, we have a lot of opportunities, a lot of different approaches we can offer to the patients, and now we have to discuss with the patients. Here is a list of some of them. I would like to focus on the recommendation of the European Society of Medical Oncology that have been released recently, 1.5 years ago, more or less. Michele was one of the leaders on the management of these guidelines, along with Martin Dreiling. So, but with Rex, if we consider the specific of patients with relapsed disease, for those patients with localized disease and low tumor burden, there is room for a watch and wait policy, but for most of the other, there are a lot of opportunities, starting from chemoimmunotherapy, high-dose therapy, and radioimmunotherapy, and so on. I would like to focus on the role of high-dose therapy in this setting. So I don't believe that this is still a hot topic. So we could define warm or probably cold topic. So we don't need to offer a high-dose therapy to all the patients. This is the picture of the real world 342 patients diagnosed with follicular lymphoma in the province of Modena, the town where I live, in 15 years. So just the residents in that area, no bias, no selection, no patients coming far from Modena for second opinion. In this group of patients, only 4% of these patients were offered a consolidation with high-dose therapy, and probably most of them were in clinical trials. We do not offer anymore. And in the group of 124 patients, 7% were treated with high-dose therapy. So it's an option, but it's not so frequent outside of clinical trials due to age or to the extent of the disease. Although we know that basically on the CAP trial, a very old trial with limitation in patient accrual, was a study that was opened for a long period of time. But so what was impressive, any kind of high-dose therapy with purged or unpurged cells were superior to chemotherapy alone at time of relapse. Also, in my presentation, there are some statements coming from the Silvia Montoto consensus document, consensus paper. So, with respect to patients with relapsed disease, high dose is appropriate, is not mandatory, is appropriate in this setting, and also you can consider the role of allogeneic transplantation. We tried to see when high-dose therapy should be located in patients with follicular lymphoma followed since time of first diagnosis. This study was realized as a retrospective analysis inside our foundation, the Fondazione Italiana Lymphoma, and has been recently published. What we did was to try to understand the best combination of first-line therapy and salvage therapy, and also to see the efficacy of salvage therapy and also related to the first-line treatment. And we grouped all cases in three groups. Those patients treated with alkylating, chlorambucil alone or CVP, with or without rituximab, anthracycline-containing regimen, most are CHOP, and those containing nucleoside. And we only considered patients that had second-line therapy starting in 2000. So that means most of them in first-line therapy have been treated with rituximab, not all, but almost all patients treated for second-line therapy had the opportunity to be treated with a rituximab-containing regimen. And these are the results of this study. Okay. So the group of patients that received high-dose therapy as a salvage therapy did better compared to all the other combinations. And the combination of anthracycline-containing regimen followed by high dose was superior to all the other combinations. So from this retrospective analysis, we concluded that high-dose therapy could be an option. Of course, being a retrospective analysis, we don't know how many selection bias are, but at least it's not detrimental. And these results are better achieved if we start with an anthracycline-containing regimen. These are the conclusions that we can summarize from this study. And in this slide is better defined the difference between the group treated with high-dose anthracycline first and high-dose therapy at time of relapse with all the other combinations. And so the conclusion is that this is the best combination outside of a clinical trial based on retrospective analysis. Then we tried to see if this was true also in a smaller but controlled group of patients. We updated the salvage therapy of the more than 500 patients that have been enrolled in the Follow-5 study. So 200 patients were retreated due to progressive disease or relapsed disease. The majority of them were retreated with chemotherapy, but 19% of these patients were treated with high-dose therapy as first treatment, treatment of first relapse. And what we found was, in terms of progression-free survival, apparently no difference between those treated with conventional chemotherapy and the others. The difference seems mostly due to the better outcome than expected of the control group. So, and also in terms of overall survival, it seems that there is no benefit, no additional benefit of high-dose therapy compared to conventional chemotherapy. But another question is, if there are limitations probably in the value of high-dose therapy as salvage therapy, is there room also to reconsider radioimmunotherapy as salvage? So, Armando also mentioned some results in the same study. What is important to see that there is a difference between Zevalin and conventional chemotherapy, although most of these patients were treated without rituximab. So based on this and some other results, some other studies that have been performed so far, the Fondazione Italiana Lymphoma launched this randomized phase 3 study. Patients who need salvage therapy after relapse and achieve with salvage therapy a complete or partial remission are randomized between radioimmunotherapy or autologous stem cell transplantation. I will move a little bit more in detail. We plan to enroll in this study mostly patients that have been treated with R-CHOP or R-FLUDA or RCVP, because at that time Bendamustine was not allowed as first-line therapy. So we imagine that the majority of our patients will receive Arbenda at time of relapse after 3 courses of Arbenda or some other kind of induction regimen. Those in complete or partial remission are treated with RAC just to achieve, along with rituximab, an in vivo purging. Peripheral blood cell will be collected and saved for all patients, irrespective of the randomization arm, and then patients will be randomized between the two. In this study, it is most important also the investigation of the meaning of the minimal residual disease. The study has been launched 2 years ago, and we have been treated probably, we have enrolled 70 patients in this trial. So the enrollment is lower than expected, mostly because we have less relapses following first-line therapy due to the efficacy of first-line therapy or the efficacy of maintenance therapy. And what about new drugs? I will mostly focus on these 2 molecules. Bendamustine, as previously shown, has been diffusely tested and used in follicular lymphoma in first-line therapy in relapsed setting with very promising response rate, and so we conclude that it is an effective drug. And these are some experience from the Fondazione Italiana Lymphoma. In the group of patients with follicular lymphoma treated at time of relapse, we observed 72% of an overall response rate. And in first-line therapy, the study coordinated by Umberto Vitolo, in first-line therapy, in addition with rituximab, the combination is absolutely effective. And the same seems to be for lenalidomide, used as a single agent you can observe that in the group of patients with follicular lymphoma, used alone, there is a promising overall response rate. And if you move to the combination with rituximab in the group of patients with refractory or relapsed disease, you can see that three-quarters of the cases exhibit a response to salvage therapy. And for these reasons, the Fondazione Italiana Linfomi launched this study, the Renoir study, for those patients who are unfit for high-dose therapy at time of relapse, so cannot be enrolled in the FLAS-12 study. For these patients, we offer a combination of lenalidomide plus rituximab. This is the study design. Patients at time of relapse are treated with 4 courses of Benda, and then are randomized with the combination of rituximab and lenalidomide or rituximab alone. And this study has been recently opened to accrual. In this study, there is the participation of 50 centers all around Italy. And what happens at time of second or further relapse? Of course, if we used R-CHOP, Benda at time of diagnosis, and we used Benda or Zevalin or high-dose therapy at time of first relapse, here there's room to consider different approaches, and this is the area where currently have been investigated the new drugs, both in the area of the monoclonal antibodies and also the other promising new agents. And so the group of patients that are candidate to high-dose therapy is very, very limited. So the list of promising new agents in the area in the group of monoclonal antibodies is continuing expanding. So Armando showed how many potential targets are available. In this slide, I also added the anti-CD37. That is another promising target. And several experiences are on the humanized anti-CD20, on the anti-CD19, and probably some is emerging also on the role of anti-CD37. So in the group of the humanized anti-CD20, the GA101 has been reported by Gilles as absolutely effective in patients with relapsed or refractory. These are the results of the Gauguin study. So the overall response rate is very promising, with more than 60% achieving a response. And also, it was a dose effect well documented that this allowed also to definition of the standard dose for new trials. And also, the combination of GA101 plus conventional chemotherapy, CHOP or Fluda and Cytoxan, so documented a very high response rate, 93% in this group of patients. So we have to wait the final results of this combination, but it is probably true that the combination of GA101 with some chemo will be of help for the patients. Some results are emerging in the group of follicular lymphoma with the use of the anti-CD19. In the group of follicular lymphoma, we have relapsed and refractory. We have 30% of overall response rate. Recently has been also published a paper focused not only on indolent lymphoma, but also in diffuse large B-cell lymphoma in this paper released very recently. So the case report was for diffuse large B-cell lymphoma, but some results have been also reported for patients treated for patients with follicular lymphoma. So this combination, the use of the anti-CD19 chimeric antigen receptor associated with T-cell, so seems a new promising strategy for treating these patients. And also the anti-CD37, the beta-lutin, is a radioimmunoconjugated. The radiolabeled antigen is the lutetium. And in this study, mostly like in the Zevalin experience, there is a loading dose of rituximab alone, and then there is the treatment with beta-lutin. In the group of patients with follicular lymphoma, some complete response and partial response has been observed, and now a trial is been starting in a randomized manner. I don't spend much time on these new molecules, just to remember that most of them have been tested in indolent lymphoma and follicular lymphoma in particular, showing promising efficacy. This is the experience with ibrutinib. This is the idelalisib has been recently approved by HEMA based on these results, so it can be used not only in CLL, but also in patients with at least 2 relapses, patients with follicular lymphoma after at least 2 relapses, and also this seems promising. And also there is room for new compounds, Also the anti-PD-1 seems to work well in patients with follicular lymphoma. This is an experience performed at Houston. You can see the majority of patients had a response as a single agent, and probably there is room also to include this new drug in combination regimen. So, in conclusion, what we can what we can say as take-home message. So for patients with relapsed or refractory disease, we have to distinguish if we have to treat patients at first relapse or at maximum second relapse. And for these patients, probably we can also start with a treatment at curative intent. In our cooperative group, we offer the FLAS12, so the comparison between Zevalin and high-dose therapy for those patients aged less than 65, or for the others, the lenalidomide trial. And for second relapse or for elderly patients that are the majority of patients, of course, the idea is to explore the efficacy of new drugs. And thank you for your attention.